Okay, starting to get folks into the room. Gonna give it a minute or so to make sure we have the people who are interested in this session on case study number 2, the Carilion Bridge to Treatment. So let me give it a little bit more time, and I'll repeat this again, but we will be having a presentation. And people, as they are listening, if they have questions or comments, they can put them into the chat, please. Again, we're just getting people coming here, and so I'm going to keep saying this a couple more times as people are sorting out which of the first 2 rounds of case studies. So we're glad that you've chosen us for the first round. You'll have another round at about 11:35. So glad you're with us for the first round, and then you'll get a choice for another one of the very fine topics we have here. I'm John Stevens, I'm the moderator. I'm going to say this for just a minute or 2 more so we don't cut into our time too much, but I'm certainly not going to do 5-minute intro. I'm going to keep it much shorter than that. So I'm really glad that we have people from across Virginia, across the country, interested in equitable collaboration and a rich menu of case studies. And Dr. Hartman and Dr. Hartman will be turning it over to them in just a minute or so. I know this is easy for some people, the idea of moving into breakout rooms and choosing which ones they want. And others, it may be a little more challenging. So that's why I'm going to give it just a moment more, and then we will start. For people who've just joined us, as the presentation goes forward, please use the chat feature at the bottom bar. It has that balloon where you can click on that and offer a question or comment, and I'll be monitoring that and then bring that into our discussion after the presentation. Okay, so we don't go too late. We'll go get started, and Cheri and David, I'll be monitoring, and if there's a whole bunch of people that join us, I may pause your presentation for a moment just to recognize them and then go from there. So welcome. This is case study number 2, Carilion Bridge to Treatment. I'm very glad to introduce our presenters, Dr. Cheri Hartman and Dr. David Hartman. How this is going to go is in a moment, I'll turn it over to them, and they'll have about 20 minutes for their presentation. As I've mentioned, please add questions or comments as you're listening in the chat box. I'll also be listening for a few highlights coming out of that. And then at 11:20, we're going to go to inviting the questions. I'll bring them in from chat. Just to manage our expectations as we add people and have a wider array of questions. Sorry if we don't get to your particular question. I'll try to combine them as necessary. And as a highlight for my fellow academics, Cheri and David, please try to answer briefly so we get to as many questions as possible. And with that, I'm turning it over to Dr. Cheri Hartman, who is administrator of the Department of Psychiatry and involved in opioid treatment at the Carilion Clinic in Roanoke, Virginia, and Dr. David Hartman, also of the Carilion Clinic of Psychiatry and Behavioral Medicine. Over to the Dr. Hartmans.
Well, good morning, everyone. Greetings from Roanoke, Virginia. And thank you, John, for facilitating and for your introduction. Before I do the screen share, I do want to just do a little bit more information about ourselves. So I am Cheri Hartman, and I am with the Carilion Clinic Office-Based Opioid Treatment Program as the director. We call it our OBOT, and it is in the Department of Psychiatry in the outpatient section. I am a psychologist, but I work really more in an administrative role in this program, and I work alongside my husband, Dr. David Hartman, who's the lead physician in our outpatient treatment program. And the good news is that our marriage is surviving, working every day together in this program. Together, Dave and I created the Office-Based Opioid Treatment Program, the OBOT, on the basis of Virginia's ARTS initiative. ARTS is the Addiction Recovery Treatment Services initiative that is policy in Virginia that really embodies equitable collaboration. So I'll talk more about that later. I'm going to go ahead and do the screen share to introduce to you the team that has collaborated to form the Carilion ED Bridge to Treatment program. All right, our screen share I think is up, and I want to tell you a little bit about this collaborating team. Besides Dave and myself, who are on the receiving end of the bridge, this bridge team is led by the chairman of the emergency department here at Carilion, John Burton, along with his other ED physicians and the case managers in the emergency department. They play the important role of getting our patients on the path to recovery and taking those first steps onto the bridge. Other key team members, you'll see listed here, Erin Casey Trend, she's gotten married now. She is the supervisor of the Peer Recovery Specialist program that she actually created here at Carilion. The peers are a very important part of this team. They are individuals with lived experience, and they support our patients every step of the way. I want to review with you, if I can get this to go forward. Why equitable collaboration is relevant to our story. And I think that will become clear when you learn more about the main characters of the story, who are the patients that we serve. These patients have an opioid use disorder. They struggle with the disease of addiction. And all of these patients have suffered terrible trauma throughout their lives. So the acute medical trauma that brings them into the ED is really just the tip of the iceberg. On this slide, I hope you can see in the background of the slide is my iceberg, and overlaid on the iceberg is text that describes the nature of the trauma that has plagued our patients throughout their lives. Now, what you see visibly when they come into the ED are the physical events. They might come in because they've overdosed, and they might be revived right in the ED, or a first responder might have brought them into the ED. And of course, that is a traumatic event. Or they might present in the ED in withdrawal, and they might be suffering from acute withdrawal symptoms that is created by the withdrawal from opioids. The way our patients describe that, this is a withdrawal that's like comparable to the worst imaginable flu that you might have. You know, that kind of flu where you hurt from head to toe, every bone of your body hurts. And you feel that nausea where you just want to throw up everything that's inside of you just to get that feeling out of you. Terrible headache, fever, chills, a lot of discomfort. So yes, they come into the ED looking for relief of these distressing physical symptoms. Or they might come in with infections. They might have a very serious cardiac or respiratory complication that gets addressed in the ED. According to our patients, even worse than the physical events is the psychological trauma that's been a part of their lives, typically for a long time. They will tell us stories about really cruel childhoods that they've had, marred by just horrific abuse as a child. More recently, they might have suffered the loss of a family member, of a close friend. Their child might have been removed from their home. They might have lost their jobs, lost their freedom, being incarcerated, lost their housing and been evicted. Just numerous psychological traumas in their lives, but they say the worst trauma of all is the loss of self-worth, the shaming that is a part of their experience. And unfortunately, too often, the very place that they turn to for help is where they get the worst shaming. In our ED, there is an effort to flip the script on that, if you will. And I just want to highlight, you may be aware of just how serious the problem of the opioid epidemic is. Unfortunately, it's taken a severe turn for the worst in 2020 across the country, and specifically in Virginia. The Department of Health has released a recent report that in 2020, the overdose fatality rate has skyrocketed. We expect that when all is counted, that 2020 will have seen over 2,200 fatalities caused by drug overdoses. That compares to closer to 1,600 in 2019, and it had dropped down in 2018 in the mid 1,400 range. So there's been a real spike in the level of mortality. Also, in general, in 2020, we saw a decrease in the number of ED visits. A lot of people wanted to stay out of the ED, right? They were afraid to contract COVID-19. But the exception to that is the spike in ED visits related to drug overdoses that we saw in 2020. So the problem was compounded, no doubt, by the pandemic. We are making progress here at Carilion in addressing the opioid epidemic, but what I like to highlight is that we need a lot more bridges to treatment. We also need a dramatic increase, if we could, increase our capacity on the safe harbor side, the shoreline, the receiving end of the bridge. We need more providers in outpatient care. And of course, ideally, we would accomplish more upstream along the lines of prevention, early identification, and early intervention. So that brings me to telling the story of our ED Bridge, which I'm honored to share with you today. My hope is that we can inspire more communities to put into place these bridges to care. It has been built collaboratively. I think you will see in here a lot of the elements of the principles of equitable collaboration. It all started with the open-mindedness of the chairman of our emergency department, John Burton. I remember the day he met with Dave and I. He had come back, and it was in December of 2018. And he returned from a conference where he'd been inspired by a presentation given by Dr. Gail D'Onofrio, who had started an ED bridge to treatment up at Yale. And he met with Dave and me. He knew that Dave had a long-standing history of treating heroin addiction, and most recently providing MAT, which stands for medication-assisted treatment, to persons with an opioid use disorder. And John acknowledged that he had a lot of hope for patients who get into outpatient treatment. He felt that they would learn how to manage their disease with the likelihood of success being in the outpatient program, combining the medication-assisted treatment and therapy. But he wanted to rethink the role of the ED in the opioid epidemic. And he wanted to be a part of the initiation of patients into treatment and to take advantage of the opportunity, the unique opportunity that ED doctors have. So with great humility, honestly, and open-mindedness, he was really rethinking the relevance of treating addiction in his world. So he took the lead, and he completed the 8-hour course that's required of physicians in order to be authorized to prescribe MAT, medication-assisted treatment, specifically buprenorphine. John completed the course, but then he also created a reward system for encouraging, motivating his fellow ED doctors to also take this course. By 2 years later, there were almost 50 ED doctors at Carilion Roanoke Memorial Hospital who had completed this training in addiction and specifically in treating opioid use disorders. He put together a team where we would roll out this bridge, and he included on that team right from the beginning peers, persons with lived experience. And he invited them to directly share their stories with the ED doctors. And you can see the impact of hearing these stories on the audience. Persons that look just like you and me, right? And they were sharing stories of how addiction had hijacked their lives. Experimentation had led to falling off that cliff into addiction. They also talked about the role of MAT on reclaiming their lives. MAT combined with therapy, with counseling. The peers were also included in the regular monthly collaborative planning meetings. Their voice was at the table on an ongoing level. And they really helped to educate us and keep us mindful of how to be inclusive. You know, what kind of language is important to be inclusive and to avoid. So when you talk about persons being treated, that you don't call someone an addict, but rather a person with an opioid use disorder. That you avoid terms like clean and dirty drug screens and replace those terms with language that reflects the symptoms of a disease. So this collaborative team met, and we did embrace the adaptive responsive process that was talked about earlier. We are funded to do quality improvement study of the ED bridge. I get to do that with the help of the funding from the Virginia Department of Health. And the team itself, I feel like the key contribution is it's provided this missing piece in the puzzle, the knowledge that addiction is not a moral failure, that it is in fact a treatable but chronic disease that affects every family, most every family in America. And now I'd like to switch chairs in this duet with my husband, Dr. David Hartman. I am going to have him tell you the physician perspective. All right, let me take over that chair. To your right a little bit.
Hello, I'm David Hartman. Just to understand, I happen to be blind, so I may not provide much visual perception. I'm going to wind the clock back about 4 years. And what we experienced was these desperate patients who struggled with the disease of addiction, who would go into withdrawal, as Cheri just well described, had this terrible flu-like syndrome. They'd had cravings, and they would end up in the emergency room desperate to get some type of opiate. Sometimes they would give a sample of urine, prick their finger, put a little blood in it, and say, I think I'm having another kidney stone. So they get opiates for their pain. Another individual, I'll never forget, said he was so desperate to get opiates that he actually poured boiling water on his leg so that the pain would be obvious. The ER doctor would give them opiates. On the other side, of course, are the emergency room doctors who were feeling betrayed, manipulated. They were feeling that these people would come into their ER every week looking for opiates, and they were very, very angry. And while they acknowledged that it's a disease of addiction, they felt that there was these individuals were manipulating them and that they were morally depraved individuals. So when Dr. Burton proceeded to encourage all these doctors to get waivered in Suboxone, they learned firsthand about the the disease of addiction. They learned about it very carefully, but more important, they were given a tool to work with it. They were taught how to use buprenorphine to be able to manage these individuals. So the ER doctors now became empowered to be able to do something for these desperate patients. So just to give you a scenario, a patient comes into our emergency room desperate, craving, and having severe withdrawal. Now the ER doctor knows what they can do. They can give them buprenorphine, a medicine that provides relief from the cravings, and also a blocker that if they happen to relapse and use heroin, it will be blocked. So the emergency room doctor has a tool to administer. They also call peer recovery specialists in who will work with the individual in helping to get this person into our office-based opiate treatment program, where we manage them with buprenorphine, and we also have groups to give them the support. The ER doctor not only gives them buprenorphine in the emergency room, but then they give them a week or 2 weeks supply to bridge that move from the ER to our office-based opiate treatment program. And so now patients feel supported, they feel acknowledged, they feel recognized for the trauma they're experiencing, and the emergency room doctors feel welcoming, supportive, encouraging, and feel at some level they know what to do now. And the relationship has really become very positive. We thought that the emergency room would suddenly become a source for everybody to seek buprenorphine, but in fact, it's become a starting spot where people can be stabilized and referred. And the number of people with addiction are actually becoming less and less in the emergency room rather than increased. These individuals are getting the care they need and deserve. The doctors feel fulfilled.
All right. We love hearing the stories from the patients when they come into outpatient care, and they just kind of marvel at being treated with respect in the ED. So it's nothing short of a major culture shift that has been propelled. I won't read to you all the quotes, but just I'll mention Dr. Karen Keel kind of summed it up, who said the ED bridge has replaced hopelessness with hope, frustration with a rewarding sense of accomplishment, of making a difference. And it all started with some open-mindedness on the part of Dr. Burton and a willingness to rethink one's ideas. So as Dave mentioned, these tools are available in the ED. Folks feel like they can get a handle on this disease. The relationship is based on mutual respect, and the whole program depends on that sense of collaboration and mutual respect among all parties around the table, including between the team and the patient. So the big enemy to me in the field of opiate addiction is stigma, the shaming. And that has gotten replaced with understanding the disease of addiction better. The other thing that has happened is a better understanding about the treatment itself. I mean, Dave and I felt like pariahs up until a few years ago. I was literally screamed at a couple of times. Why am I providing this poison to patients? As if buprenorphine was just, really a poisonous substitute for heroin and for, the pain pills that our patients had become addicted on. People did not understand what Dave was talking about, that the medication itself leads to this neurological stabilization of the brain. And so the patients talk about, how the medication has helped recalibrate their brain, reclaim their true selves, they'll say. It does quell the cravings, as Dave mentioned. So there's this biochemical process of calming cravings, which are a biochemical experience. It blocks the harm because it attaches so strongly to the mu receptors in the brain. It can block the harm from heroin and the potential of overdosing. And combined, we believe strongly that it needs to be combined with therapy, case management, peer support. The patient can succeed at disease management. So we do have some results we can share with you from our quality improvement study. The first year, so we included in the study those patients considered appropriate for outpatient care. If they went into inpatient or the hospital, they weren't in our study. But we looked at the success of getting patients into outpatient care. We were referred 77 patients, 63 of them got into our treatment, a success rate of around 82% in year one. And I just finished the year two report. We had in this year almost 200 patients referred into our care. 154 of them crossed the bridge successfully. So it's a success rate of about 78%. This contrasts with what Dr. Burton had told us. In 2018, he said, Cheri, Dave, I think we're only getting about 5% of people referred into treatment from the ED, 5%. He's like, that is just not okay. And here we are today. It's a much higher success rate. Dave reviewed with you already, how they received the buprenorphines in order to alleviate withdrawal symptoms, and that they are also given a script. That's what their training certifies them to do, is provide that prescription that they can then fill at the pharmacy. Providing a medical bridge, a continuity of care kind of scenario to get into outpatient treatment. More and more of our overdose survivors who are being revived in the ED are actually remaining there to get into withdrawal. You can't give buprenorphine until you're in withdrawal, or else it'll make you very sick. So they stay there long enough to get into withdrawal, get the buprenorphine, get the script, and come into outpatient treatment. And actually 100% of the ones that were revived in our ED did make it into outpatient treatment. So our conclusion, the impact of this is cultural. I mean, it's a huge impact on the very culture of the ED, moving from a culture of shaming to one of humility, open-mindedness, and compassion. And guess what? Doing that doesn't take more time. Time is a big variable in the ED, but that equitable collaboration with the patient gets results. I do want to just highlight that the Arts Initiative at a policy level endorses equitable collaboration. The Addiction and Recovery Treatment Services did this in a number of ways. One is it created this interdisciplinary comprehensive care model that is the hallmark of the OBA, office-based opioid treatment. Care coordination is reimbursed. For the first time ever, we could get reimbursed for care coordination and address those barriers to accessing treatment that used to impair the ability to remain on the path to recovery. Things like what we mentioned earlier, the traumas of homelessness, today, lack of internet access, and so on, loss of child removal from the home. We're able to address those really critical factors using care coordinators and the support of the peer recovery specialist, which also is now in Virginia a billable service. So with all of us collaborating together, we can partner successfully with our patients to create these bridges to care, not just in Roanoke, but communities throughout Virginia and the country. Thank you all so much. I'll stop the share.
Great. Thank you, Dr. Hartman. And let's move to questions or comments. Luckily, we're not too big a group. While I see, let's see, from I'll go first to in the comment from Janet Stark. Great to hear more directly about this work. For what it's worth, there are several strong examples of the role of art and music therapy in treatment as well, including here in the Commonwealth. Has that been a dimension of your approach, or what's your thoughts related to Ms. Stark's comment?
Well, I love that. We in our OBA don't have access to art therapy and music therapy. Where we see that in place is on the inpatient units, where the patients are there for a long period of time. And they do have incorporated there art therapy and music therapy. And I always love hearing about it from our patients, when they are discharged from inpatient care. They really appreciate it. We don't have intensive outpatient program. So ours it's a fairly brief therapy opportunity with them. We do meet weekly. typically for about 6 months, but it's in these briefer therapy sessions. But we're hoping to actually expand into providing more of an IOP kind of setting where you would have more of a variety of kinds of therapies. But thank you for your question.
Okay, who's next? Kevin Harris, can you speak to the O/P scale in Virginia? So beyond your OBOT, what policy barriers other than money prevents scaling this up? Lack of providers, lack of scope or of practice laws? So I hope you understand the O/P reference, Dr. Hartman and Dr. Hartman.
Yeah, well, do you want to answer that?
Go ahead.
So there are significant barriers policy-wide to expanding capacity. There is some hope that we'll be able to remove the requirement to complete the 8 hours of waiver training to be able to prescribe buprenorphine. They make it really hard to prescribe buprenorphine, but not so hard to prescribe Dilaudid, So we would love to see policy changes that would increase the numbers of providers. There's a dire lack of outpatient providers that doesn't even come close to meeting the needs. There's also all kinds of glitches that happen in the system. Peer recovery specialists specifically, it's very, very hard to actually implement the billable service. It's hard for hospitals to reinvent themselves. Hospitals are very difficult animals to get them to reinvent themselves. So, if we could get policy changes that would make it more user-friendly, that would go a long way.
Okay, great. And again, thanks for keeping the answers moderate to brief. We want to get as many as possible, and I've been putting in at least some notes from that. So thanks, Ms. Stark. Thank you, Mr. Harris. Other folks, questions or comments? Again, we're small enough that if you do want to unmute and do something quickly, that's fine. We're at about 3 or 4 minutes remainder for this session. So I'm keeping an eye on the chat, or if someone wants to unmute and say something, put their question directly, please do so. Sometimes feel I should have the Jeopardy music running in the background for this kind of thing, for encouraging participation. Again, I'm just looking at folks, seeing if we're going to get an unmute or anything else people want to put into the chat about the bridge, Carilion bridge that we've been learning about. Kevin?
Yeah, John, since there don't seem to be other questions, I won't feel too guilty about sucking up the bandwidth here, but I'm very curious to both the doctors if they have some experience, thoughts on there are a lot of peer support networks all over the country in a lot of areas, not just in substance use disorders, and they seem to be effective. I mean, they're sort of cutting edge. I'm just wondering, do you have any proud moments about why your program, how you implemented your program and maybe did it differently or similarly to other programs around the country? And if so, distinguish the way that you set that up in terms of the inclusivity of your peer networks.
I would say the key thing here at Carilion is top-down support. I mean, literally our CEO and president loves our peer recovery specialist program and has endorsed it. We do not make any money on it. We have not navigated the reimbursability of peer recovery services, but our system covers the cost of it because of its effectiveness. The peers, whether they're in the hospital setting, they have actually reduced patients from leaving AMA because of their impact on inpatients. Their success, I mean, our patients are at least twice as likely to navigate that bridge to us when they have the support of a peer. The peer can follow them wherever they go, whether they go into outpatient, inpatient, Carilion, or somewhere else. They can follow them. And the difference that makes is immense. And it takes a system endorsing the importance of that for it to work.